Yep. Thanks, Megan. Well, good afternoon, everybody. Happy Friday. This is Eric Boyer. I'm the Senior Program Officer at the Alaska Mental Health Trust Authority. And it's our pleasure to partner with the folks at RIA International and Agnew Beck in bringing you the next in our series of webinars, really focused on getting some of the knowledge and expertise that Georgia Madeira and Dr. Chuck at RI today, but the series of presenters that we've had from them, just from their experience, their expertise, the years and decades that they've put into really supporting crisis stabilization for people in need out in community. So glad that you guys can make it. Really today looking at safety and security, just thinking about the milieu, the atmosphere that we want to see developed in those levels of crisis stabilization. And that's something that as we think around the best practices that come with crisis now and crisis stabilization, Dr. Chuck and Georgia have really gotten to build that best practice and really support the staff teams in those environments, but also look at how that directly impacts and supports beneficiaries who are struggling with those mental health issues that really need that level of need, but in a least restrictive setting in our communities. And as you all know, that's something that the trust and our partners have really worked hard to support here across the state of Alaska. So with that, glad you guys could all make it, and we will pass this over. Megan, is we passing it to Georgia or Dr. Chuck first?
You can take it over.
Thanks, Georgia.
Sure. Hello, everyone, and thank you so much for making the time to be with us today for the Safety and Security for All webinar. I'm Georgia Madeira, and I'm a Senior Principal Consultant with RI International. And today it's my pleasure to have Dr. Chuck Browning, who is our Chief Medical Officer and also an expert in the Crisis Now model, to talk to us today about such an important topic in crisis care, safety, and especially for us at RI, we take this topic really, really serious. It's one of our key priorities, and making sure that the people that we serve are safe, but also our team members are safe. So here's Dr. Browning.
Thanks, Georgia. So I'm looking forward to being able to talk with everyone as I get my screen up, and I need to do a good job because it sounds like I'm going to be doing a few more of these over time. So got to get this right from the beginning. Can everybody see the screen okay?
We see your presenter view, Dr. Chuck.
Oh, well, that's not good. Let me crank that out.
Chuck, if you go back there, it's an easy fix. There you go.
How's that? Can you see the presenter view now, or is it clear?
It's
Nope,
good now.
Great. Great. So thank you again for everyone for inviting me to be able to talk about this. It's a subject that's near and dear to my heart because it is important, so important in the way that we care for people that are in crisis. And so as an intro into this, thinking about safety and security for all, obviously we're going to be talking about the context of crisis care and the crisis continuum, but to really get started out, I want you to just think about how do you define safety or security. And if you think about it, there's a lot of different versions of that for different people. There is, a sense of emotional, psychological safety. There's physical safety. All of us have different variations of how we interpret our own sense of safety based on our temperament, which is based on things related to our genetics, exposures, and experiences that we've had in our life, situations that we're in. It can even vary day to day and hour to hour based on how we're feeling in terms of, are we nervous about doing a presentation in front of people, or are we feeling really well rested and just coming off vacation or after a recent triumph? Can have big effects on that level of how we do that. And so how we feel and how we feel about our safety and security can have a big impact on our thoughts and the way we see things. So this is a little bit of a humorous slide, but it's kind of got an example of thinking about, safety. You can be focused on some things related to safety and miss some other things. So we're going to talk about that today. And I appreciate you having me here. I go by Dr. Chuck. I'm the Chief Medical Officer at RI International. I'm also Medical Director at Behavioral Health Link out of Georgia. And so at RI, we really specialize a lot in the crisis receiving center care, as well as thought leadership about overall crisis continuum. But then also I have the expertise and experience of working with our teams at Behavioral Health Link in the call centers and the mobile support team. So I hope I'm going to be able to give a kind of a universal description of thinking about safety and security and crisis lines over everything. So I'm going to start with a little bit of a story about safety and show off a picture of my oldest son. This is a year or two old, but this is his senior high school graduation pictures. He had his little football sweatshirt top on for the picture, trying to look all macho. He played linebacker and, pretty physical position. But that is not always this little tough thing of what he was. This is a picture of him at Disney World in Epcot. He's actually cute and looking relaxed and not very in danger there. But when he was just a couple years younger, if we went to Disney World, or if we were at the state fair and there was a character there, or if we were at a football game or basketball game with a mascot, any person in a costume, like if Donald Duck came walking out, he was jetting. He was not going to put up with that. He did not feel safe at all. It terrified him. And I'll tell you a real quick story that it kind of shapes some of the things I'm going to talk to you about. Is that when he was a little bit younger in that young picture, we went to a Halloween party, and he was already on edge because there was all kinds of Halloween decorations. There was like a big animated or mechanical mummy that when you walk by it made noises, so he wouldn't go to the front door anymore. We did a hay ride that had some little scary like spiders hanging down and things like that. But as we're walking out the door down the driveway to go back to our car to go home, there was a dad who was playing pranks on people coming out of the woods with a Halloween mask on, scaring people. And CJ, like I said, was quite a bit younger than this age. And that dad came out at us. We didn't know he was there. And he was terrified, but instead of like jumping behind us or jumping up in our arms or going after the person, he just took off into the woods, just like bolted from all of us and just took off into the woods. And the dad was really upset that had happened. And I mean, he went from what was not that dangerous of a situation, but because he was terrified, just running into the woods in the dark, not even knowing what he was seeing. And so I tell that story. It all worked out okay. And he knows I'm telling this story about him and actually got a tickle about it. We still tease about it. But it is going back to paint that picture of how we feel related to safety. Sometimes we can make judgment calls that can put us in danger. And that can be true whether we're serving people or whether it's the people we're serving. So I hope today I can give you a little bit of story about thinking about that, thinking about those elements, thinking about how we can design systems in your area that help decrease the chances of those kinds of interactions happening. So as you know, one of the things that we're really thought leaders in talking about is the crisis now model, which is that having a call center, we're having someone to call, and then also having the crisis mobile teams, which is a group of someone to come to you if you need that level of care, and then also the potential of, if you need somewhere to go into a crisis receiving center. And so thinking about that concept, we're going to talk about today a kind of a global view of thinking, how do we have safety and security in those elements? And it actually has a strong foundation that's been talked about and written about in SAMHSA's National Guidelines for Behavioral Health Crisis Care in their best practice toolkit. I was fortunate enough to be one of the contributors to that document. And everybody always talks about those three elements of crisis now, but one of my favorite things to talk about is the fourth thing, which is the essential crisis care practices that go into this care model. And so when you think about that, there's several things. One of the most important is addressing recovery needs, significant use of peer support, trauma-informed care, having suicide safer care. But then look at what number 3 is: safety and security for all staff. And then obviously the last one, coordination with law enforcement and emergency services. So we're going to really focus in today about where does this safety and security specifically work in the elements of the crisis continuum. So my first question, and I'm going to open it up to folks, and I got to see if I can see the screen, is in the chat. Any thoughts about when you think about safety and security related to crisis care, what kinds of things come to mind? Because remember, we all have versions of what is things about safety and security. So what comes to mind when you start thinking about safety and security related to crisis care? I'm gonna have to call on somebody if I don't get if we don't get some chat responses. Any thoughts or questions, concerns that you have when you think about safety in that? Oh, thanks, Tina. Highly agitated individuals who are in crisis. Overall safety for staff and person who is being supported. Thanks, Eric. Maintaining a safe environment. And individuals who are under the influence of drugs or alcohol, situational awareness. All these are great. And I'm hoping that I'm going to give you a lot of insights into some of our work with these elements and put it in a framework that'll make it easy to remember and easy to think about as you go forward. So first off, we're going to talk a little bit about why it's important to be thinking about safety and security and have that feeling. I love this slide and this quote from Maya Angelou. That's they will forget what you did and what you said, but they will never forget how you made them feel. We use that as part of our training for our staff and really talk about thinking about how we make someone feel cared for in their moment of crisis, because it's one of the most healing things that we can do. However, if you think about it in terms of a person being served, kind of like my son CJ, when he was terrified and didn't feel safe, the last thing he was thinking about was having that crisis de-escalated. He was running into the woods into danger. And so when we're thinking about trying to create a healing, caring environment for people that are in crisis that helps them de-escalate their crisis, the more that we can help them feel safe and secure in what's going on, the more impact and effectiveness we're going to have in resolving their crisis in the moment. So that's one element, is that actually we're doing it. One of the reasons we're doing it for safety is for good care for the people that we serve. But the other element goes into our staff, which someone mentioned in the chat, and I really appreciate that. And that is, our staff needs to feel safe in order to provide that experience. So I use this slide talking about Disney, and we do a lot of training and things that we do for our staff outside of Disney. And I'm going to go much more in depth of that into one of our future talks coming up soon on the fusion model. But guestology is a thing at Disney. It's the study of kind of best, and they do such a good job at understanding what a guest at their parks wants, needs, what their expectations may be, and how to even work on going above and beyond what their expectations would be to kind of create some magic. And they execute that with a really large staff on a consistent basis. And what they're aiming to do is to create a feeling, an experience of family fun when you go there. And they're pretty well known for doing a good job with that. So at our work, and I would argue that for all crisis care, that what you want to do is create a similar guestology experience. Understand the people that we're serving, what they want, what they need, and what their expectations are. And instead of creating an experience of fun or family fun, we're trying to create an experience of caring in a person's time of pain or need. And unfortunately, if our staff is not feeling safe, it makes it really hard for them to be the best at doing that. So part of the elements of what we're going to talk about today is the why is to help bring home why you want to put these certain things into place so that your staff feels like they've got the tools and resources to provide that kind of care. Because when you are dealing with someone who's highly agitated, like what was mentioned in the chat, that becomes really important then. So we talked about the why. Now let's explore the what's. So what kinds of things do we see related to safety risks in the field of crisis care? I like to summarize it into about 4 major types of categories. And this is just a screenshot of software that we use at Behavioral Health Link for our call center. And when we're doing risk assessment pieces in the call center, we have these tablets and these push buttons to help our staff be guided through what they do. And if you think about it, almost all elements in crisis have kind of 4 major big categories of risk. There's harm to self, which could include suicide risk, harm to others, which can come in many forms of ways that someone can potentially, of why someone might be harmful to others in a setting in crisis. Other mental health concerns that can relate to risk and danger related to self-care and not being able to manage yourself, that's separate from harm to self and harm to others. And then finally, like medical and substance use concerns that can be things that can increase danger and affect someone's safety while we're working with them when they're in crisis. So those are the kind of big four major categories if you think about it. So if we're working on dealing with those risks, and we go back to thinking about the crisis now continuum, how do those translate to versions of safety with our 3 lanes? So if you think about it, there's some different environments that might shape some of the things that you might experience depending on what line of work you're doing. So for example, in a call center hub, you're still dealing with all those 4 elements of risk when you're working with someone, but the person on the call line is physically pretty safe. They're separated from the person. They're there with a phone. There can definitely be times where a call person is going through emotional or psychological challenges based on things that can happen on calls that can be really scary and disturbing at times. And so you need to have those supports built in. But from an overall risk assessment, most of their focus is on risk assessment of the person they're talking to and helping them decrease their risk, and also maybe connecting them to care that's appropriate for the fit to need of what's going on with their crisis. But when you go to mobile, I would argue that maybe mobile has the most safety variables because in the environment of any of these layers, because there's so many outside factors. So when you're going on a call, are there dogs there? Is there active weapons? Is it a safe area? Are there other third parties involved that might be part of risk to the call team as they're going out to see people? You've talked on the phone with someone to set up a dispatch to go see them, or you've gotten a call, but you haven't really seen the person yourself to know what you're going to be getting into when you get there. So there's some significant factors there. And then there's still, once a mobile team is getting to a site, they're going to be working on risk assessment, decreasing risk, connecting that person to care, those kinds of things. So we're going to talk a little bit as we get into more of the how of ways that we work on managing that safety related to crisis mobile. And then finally, what we specialize in at RI is crisis receiving center, someplace to go. And that's where, yes, you do have a stable environment and that you have a set place that people are coming to that takes away some of those variables. So you're actually dealing with just the people that you're serving. However, you do have the likelihood that if the system is working correctly, that's going to be the most high acuity of any of the folks that you work with. And to make that point, I mean, sometimes at our crisis receiving centers, you could argue that we have folks that are much more acute in the first 24 hours of their crisis at our setting with agitation or other really challenging issues related to their crisis than maybe a lot of the inpatient psychiatric units in the area where our crisis receiving centers are. That people that they would turn away or not work with, that we're saying, come on in, let's support you in crisis. Also in a crisis receiving center, if it's a environment where you'll be working with people at a longer time than just an hour or 2 conversation or interaction, you do increase also your risk of safety issues related to like potentially someone feeling trapped or feeling frustrated, potential for substance use withdrawal complications and medical things to crop up more in that setting that you would have to deal with and have the infrastructure to be able to deal with. So those are some of the what's that we're talking about in those 3 elements. Now, we've covered the whys and we've covered the what's related to safety and security in this crisis continuum. Now let's look at the how do you do it. And so let's go back to that original concept that I talked about, which is versions of safety, and that everyone has a different tolerance for safety and how to keep things safe. It's a constant tension in crisis care, because if you're asking yourself, is it safe, or how can we control safety? What's the cost of those controls? Every control that you put in to decrease risk likely creates some kind of tension to affect guest choice, guest comfort, and potentially have an effect on their improvement in their crisis because of those dynamics. So a lot of times we talk about in crisis that we end up sometimes doing things to people if we don't set up the system correctly, rather than doing things with people and being a partner in their crisis. And when we talk about crisis receiving centers, we get the fortune by doing a lot of consulting all over the country and really the world, is to get to see all kinds of hows, all kinds of ways that people are working towards supporting this endeavor. And when you talk about receiving centers, so I'm not talking about respite or residential centers, I'm talking about a center that serves as a focal point for people to come in from the community in crisis when they need somewhere to go and get support. You kind of get two buckets of places for the most part. And it's a stereotype. I'm not saying that there aren't places in between, because there are, but you get kind of two focuses. One might be a really recovery oriented, oftentimes does a really good job of involving peers, oftentimes being peer led, kind of place you would want to be if you were in crisis or if it was for your family member. But sometimes, you know, they might have someone show up that's a 250-pound person who's really upset and agitated, maybe intoxicated with methamphetamine, and pretty violent and angry. And some of these places may say, we cannot manage that. Or a place may not have full nursing 24 hours and they have someone come in with some medical complications. And they're like, you know, you're going to really have to go to the emergency room because that's not something that we can handle. We have to have everybody that has something like this go through the ED first. So you end up having potentially some barriers to access. However, if you are that family member, if that 250-pound guy is your son or your brother, you know, yes, you want them to go to a place that they're going to be taken care of, but you also want them to have access to care. You don't want them to be left to only have the option of maybe dealing with law enforcement and going to jail, or waiting in an emergency department that's not designed to deal with behavioral health and can be pretty traumatizing for days and days and days waiting to get a bed somewhere versus getting treatment started. And that happens a lot around our country. And so we have this tension sometimes, if you think about it, where you have this balance of either having barriers to getting care and barriers to access, or if a place really works on being able to handle all people, sometimes they do it by creating a pretty sterile, cold environment that has big bouncer types with people in rows and the staff stays behind the plexiglass, might be heavy-handed sometimes on medication, potentially could have a higher risk for more seclusion and restraint events and things like that. So you have this barrier of people maybe not getting access to care, or it may be a place that you wouldn't want your loved one or family member to go to unless it's your mother-in-law. So, and I kid about my mother-in-law. She's, you know, I tease by putting her in that example. She's actually worse than that. No, I'm sorry. I'm just kidding, Martha. You can delete that out, Megan. So the question is, why can't we do both? Why can't we have a place that has a combination of being able to say yes, and you're at the right place and we're to help you, but also if you've got certain potential risky issues, has the infrastructure to be able to support those people so that you don't have to divert them through law enforcement, or you don't have to divert them through emergency departments. And so that's where we talk about, in crisis at FRI, we talk about this concept called the fusion model. And it's this combination of the right door or no wrong door and saying yes, and then also being a really recovery-oriented care place that would be a place you would want your loved one and yourself to be. And we've labeled that the fusion model. And there's a reason we call it the fusion model. And you know, if you think about it, the definition of fusion is taking two nuclei and trying to merge them together to create one. And it generates this just amazing supply of clean, almost limitless energy if you could do it. It is the energy that powers our sun and stars. And we've spent millions of dollars in international collaborations trying to improve and be able to do this. It's kind of like the arc reactor from Tony Stark in Iron Man movie. Would be amazing if we could develop it. But the other thing, it's so hard to do though, because it's so hard from the amount of heat and pressure that you have to be able to push those two nuclei together. And sometimes doing these two things can be a really challenging thing. Sometimes there's a tension between folks who are in that peer world who really don't trust anything medical because of rightfully so different experiences and things that they've had. And then I've seen medical heavy leaning places struggle with understanding the power and the impact of care by being really recovery oriented, working with people instead of doing things to them, involving peers in that care. So why can't you do both? It's a tough balance, and it's something we're still working constantly on trying to balance in what we do at RI at Crisis Receiving Centers. And so I'm hoping to share a little bit of that today, especially in regards to how it plays out with safety. So one of the things, I'm going to stop and check the chat because I haven't seen it. Oh, thanks, Thea. That's an important line, so we'll get to that. So at RI, executing our hows of how to execute keeping a safe and secure environment for all for Fusion is hard. And we go back to that concept of guestology and how to do it well. And one of the things that we did is copycat Disney and look at what do they do in their work that helps them have all these different staff members with different disciplines at the parks, thousands of them, do a really good job of consistently delivering a particular kind of experience. And they do it in lots of different things, how they hire people, who they hire, the way that they manage on a day-by-day basis. And we try to replicate and copy those things too. But one of the things they do is all employees are empowered with 4 basic keys that guide decisions that they're allowed to make with guests at the park on their own without having to ask approval, and they can think through it. Safety is number 1, but then it's how you treat people in terms of courtesy, and there's rules and concepts that go with that. And that goes over efficiency. And the last thing is, and the third thing is show, which goes over efficiency as well. And that's being in character all the time and the way you engage and the way everything looks and the things that they do to help kind of keep you distracted and focused on the experience. And so we said, why can't we take those concepts of guestology and develop them into something that our staff could use to be empowered to independently think through the way that we do things? And so we came up with the RI way, which has our 4 keys of safety, peer-powered, engagement, and performance. However, it's not just a circle. We actually treat it as a rung of steps or a rung of ladders for our staff to think about. And so we always talk about that safety is the most paramount thing. But second is engagement, how well that we're going to bring ourselves and be in character that day to think about, I'm coming into this center to work towards being present for people, engaging with them, engaging with my teammates, making sure we're all on the same page, those kinds of things. And then right next to that, almost as important, we rank peer powered. And that is the use of certain peer powered practices and concepts to the care that we deliver. So it's things like being trauma informed, working with people and being collaborative, focusing on people's strengths, not necessarily all the things that are wrong in their crisis, but helping them be empowered to focus on their strengths. No force first. So always working to do the least restrictive thing. So going back to Disney, if you're in Mexico at Epcot near where that picture of my son was, you could be maybe not making great decisions, but the staff's not going to necessarily come the way they're going to interact with you. They're not going to say no. They're not going to come and attack you. They're going to work to give you in a courteous way choices to how to deal with something. So like if you try to stand in the way of a parade, they're going to say, I'm sorry, sir, the parade's coming through here. It wouldn't be safe for you to stand here. Would you like to stand over here or stand over there? They wouldn't say, get out of the way. You can't stand there. And yet that stuff happens in psych hospitals and psych care all the time. However, going back to safety first, if I am intoxicated and decide to, because I had too many margaritas in Epcot in the Mexico Pavilion, and I decide to climb up that building there, some security is going to come and grab me because it's dangerous. And they'll still be courteous, but they're going to come and grab me. And so likewise, that's how we try to train, is that safety is first. We're always going to try to engage and be peer-powered. And then performance is really important too, because not making people wait, being efficient, having an atmosphere of constant quality improvement, all those things are important in the experience. And the take home for this, and I promise you this, I'm going to talk about executing safety over the next few minutes when we get through with this, but the take home is nothing is more powerful for safety than the way you treat people, and that you're there engaged with them, that they feel like you're caring for them, and that you're working with them and collaborating. That is the #1 most important safety technique that we can do in a crisis continuum. And we're going to work over the next couple of sessions that I'll do. I'm going to talk about even more details about how we coach that, how we support it, and how we work on it. Now, we are going to go into much more technique stuff about safety aspects as well, but I cannot stress enough, that's your preventative, most important safety technique is that. I'm going to tell you a real quick story to kind of explain that. One of our nurse practitioners in Durham, North Carolina, Dr. Shana, who's a friend of mine, has worked with us for several years. She was a provider in Durham for several years and decided what was going out with friends one night in Raleigh, so city right next to Durham, and went out and was out pretty late. They had a late dinner and and did something fun. And I think it was like 10:30, 11 o'clock after the restaurant was closed, and she was walking to her car alone in the parking lot in Raleigh. And someone accosted her with a knife, and asked for her phone and her purse. And she handed it over and obviously was really scared. This guy looked at her and said, "Is that you, Dr. Shana?" And she said, "Oh my gosh, yeah, it's me." And it had been a guest at one of our Durham sites that had come in multiple times, and knew her. And he said, "I am so sorry. You have always been so good to me." Gave her back the purse and the wallet and the phone, and apologized profusely. Again, really wild story, but it really illustrates the importance of his effect on his feeling of that person's safety, and how he treated her was totally based on his feeling of connection with having a feeling that she genuinely cared about him and wanted to work with him while they were together. And things like that happen, and they make a big difference. When we ever have reviews of incidents, and any times that we have where someone has ended up in seclusion and restraint and review it, sometimes when we review it, if there's a fault, we can look and see that maybe our staff wasn't as engaged as we needed to be in the moment. And we can do coaching on, if you look, this person was seeking some help before this event happened and kind of had escalated up. And if we'd have gone in this way, it can make a big difference. Now, the last thing I'll say about this, it doesn't always. Sometimes people their reality can be challenged because of drugs, substances, or their mental health can confuse the way that they're perceiving things. And they may feel very much in danger and act to harm others or act to harm themselves in the context of while they're receiving care. And so you do have to have safety measures in place to help support them in the moment when those things happen. And so we're going to get into that piece next. So when it comes to actually executing the safety key, we kind of like to categorize that piece into 4 major elements: staffing, training, environment, and tools. That's what we at RI can control. And then at the end of this, I'm going to talk a little bit about what you as designers of the community system can control. Okay. So when it comes to staffing, there's lots of elements related to your staffing that can impact your safety. On the mobile teams, on the call center, on the crisis center side, all of those elements, the number of staff that you have and the fit of the number of staff and their interdisciplinary expertise plays a part in their ability to serve the needs of the types of situations that you're serving. So having the right staffing patterns based on the number of people that you're serving, the situations and the elements and things they're going to be exposed to and need to be able to support, you have to build and design your staffing to be able to fit that. So there can be staffing ratios. Another element of that is having the right kind of medical expertise in your staffing. So if you're at a crisis center and you're going to be needing to prescribe medicines to help people decrease their crisis, you're going to have providers available. And you're going to need nurses available to help do medical triage so that everybody doesn't have to go through the emergency room, and to be able to help do assessments of people's withdrawal from alcohol or people's response to medications, side effects that may come up when they're getting care there, medical things that come up in the middle of their care while they're at a crisis center. All those things you have to have staffing with medical expertise that knows how to be able to do that. And that's not necessarily always cheap to do, but it's an important piece. And then you have to have staffing teamwork on safety. And that's where this slide comes in to thinking about is from leadership down, does your staff, are they connected and embedded with this idea of safety culture, which constantly is able to be open and vulnerable about things that are safe or not safe and talk about them with each other, that any person at any level on the team can report safety concerns without fear of being attacked or being repercussions with them. And then you have this kind of continuous quality improvement mindset related to safety on always wanting to learn and figure out new ways to do things. So when I think about staffing, those are some of the key elements I think are super important as you're thinking about how you design your systems. Then when you get into training, there's lots of different types of training that can help when that, I guess the chat talked about like a highly agitated person. How do you help support them? So like I said before, I think the most important training is techniques that help staff understand how to engage and connect with people, because that's preventative. But separate from that, and another preventative piece is like trauma-informed care practice to make sure that we understand the neurobiology at some level about what triggers people's trauma that makes them feel unsafe. Because we don't want them, quote, running into the woods like my son did when you're working with them on crisis care. You want them to feel safe so they can engage and work on how to de-escalate and improve their crisis. But when imminent danger does occur, your staff needs to have training in techniques, holds, protective things, so that they can safely manage a situation. So that if there's a 250-pound person taking swings at other guests, other staff, or someone's trying to bang their head up against the wall and hurt themselves, do you have the ability to be able to support that without getting staff injuries, without hurting that person, with respect and care that's as limited and least restrictive as possible, to help keep them safe in that immediate moment until they can be calm, get through that wave, be calmer, and be in a place to do that. And it takes a lot of technique and training and drills to get good at that. So you also need to have I think a built-in part of your training is also drills, both medical drills, like how to do codes, how to do things, deal with people who have, cardiac arrest on the site, how to deal with people that might accidentally show up and overdose in the lobby with opioids, folks that might have seizures. You have to have those medical drills so that staff, when it happens, they know where to go grab things and how to do things. And that also includes when things go down from a dangerous perspective, that the staff has enough experience so they don't have to have their adrenaline kick up so much, so that they know what to do and they're confident in their skills and they can just manage it. We really feel like at our Peoria site in Arizona, where we have the highest acuity and the most chances that something like that situation can happen, because over 82% of people are coming out of the back of a police car in that site. And there is a lot of methamphetamine use in that area. And we have a lot of people that come in that in the first 24 hours are really struggling with being able to deal with being at that facility, and might be challenged with reality and feel like people are out to hurt them and feel in danger. And so when that happens, the training for that staff is so consistent, and they're so used to knowing how to deal with those situations, that I think most of our staff that deals in that is pretty comfortable at knowing what to do with each other and in their teamwork. And so it actually makes them less likely to engage and put someone in seclusion and restraint. And you're actually going to be more risky to have that happen when staff's really scared, or you'll be more risky in them not executing techniques right and having a chance of hurting someone or a staff member getting hurt. So having those kinds of trainings in that is important. I also think it's really important for your staff to have training, for your medical staff, like providers and nurses, to have training in crisis-related medical things. So we preach the use of these techniques from the American Association of Emergency Psychiatry for medication concepts that you use, called Project Beta, that really recommends certain types of medications, offering voluntary medications early, not using medications to sedate people or put them to sleep, but targeting the actual type of agitation or challenges that they're having. And then if for some reason you do have to do a forced medication in an imminent, dangerous emergency situation, the choice of medications makes a big difference in the person being able to get as good of immediate relief as possible with minimal chance of side effects, and also not feel sedated for the whole next day, so that they can work in their crisis. And there's some medications that get used in emergency departments and in some crisis centers that really can sedate someone for a long period of time and make them feel yucky, and it makes it hard for them to work on their crisis once they kind of have gone through that experience. And again, one of our peer power practices is no force first. Every time we have a seclusion and restraint event occur, we consider it a failure. But yet, if your staff doesn't know how to do it, you really can't serve everyone, because there will be situations where, despite all the ways that you treat people, especially if you're handling people who are there on involuntary commitment against their will, that sometimes things like that can happen. And so your staff needs to know how to do that. And then finally, you have to have that medical expertise built in to manage substance use and withdrawal complications that can occur, that sometimes can be dangerous and lethal, in terms of like alcohol withdrawal and benzodiazepine withdrawal, and having staffing and training on how to do that, as well as how to triage safely medical situations that people may have when they come in. And if your staff doesn't understand and you don't have a good training on how to do that and execute that, you'll end up either putting someone in a dangerous situation by having them in your crisis center when they needed to go to the ED for a particular issue to be checked out and stabilized first, or you end up sending too many people to the emergency department that didn't need to go there. And a lot of times they may not choose to keep going on their care path once that happens. And you may have interrupted an opportunity for them to get care and to make a decision to work on their recovery. So training is important. Next is the environment. We talk a lot and we use this concept at RI about developing a trauma-informed environment. And so where you're providing care is thinking about, can you make it a place that is as calming as possible, warm and welcoming, but yet is also safe. And so if you can kind of get a picture image of this, this is in a 23-hour observation unit. It's open, it's got a lot of sunlight, it's got a beautiful mural painted on the wall, and you can't see it unless you get up really close to it, but there's all kinds of recovery words that were put into the water ripples and some of the other textures in the paint. And we'll have guests go up and spend a lot of time reading the messages that are recovery worded in those paintings. And we have these murals of different types of settings at all of our different sites as we get them going. We think it's an important part of the ambiance and the environment. However, and I'll show you one more example of a room to get a sense of it. Another thing you'll notice, there's no plexiglass at what we call the recovery island. Some people would call it a nurse's station. And the oh yeah, Jamie said the blue rocking chairs are really supportive of our guests that may have some IDD issues, and folks that want to rock or as an option separate maybe from pacing. And so that's a really important concept, is having some of those abilities in there. However, as you can see, there's a really good eyesight from staff all over the whole room so that you can see through and see everyone and have a good level of observation. All of the things with the toilets and the doorknobs and the hinges are all like anti-ligature, so it helps decrease the risk of someone harming themselves. We have a lot of our sites have something that we would call like a peaceful room or a tranquility room, which is a separate room that's not a seclusion room. It's a voluntary place that someone could go to get away from stimuli in the milieu. We oftentimes use it for folks who've gone through trauma, or maybe someone who's challenged with mania or methamphetamine intoxication that's really kind of hyped up. They can go in there and we put chalk paint on the wall, on one of the walls, and give them a piece of chalk, and they can draw and write things and get some of that energy out and be able to converse. But it's a lot better than them feeling pent up and trapped in a smaller unit where they don't have access to do some things. So it's thinking about sensory level of trauma-informed things in the environment that you can do. Last important things about the environment that aren't necessarily the trauma-informed piece, but they're an important part of safety, is thinking about what kind of equipment you have in your environment to help support safety. So having what we call med-go bags. So things that can, along with an AED, things that in an ambu bag, and being able to rush to people if you need to, and having access to be able to get to people if they go through medical emergencies, including EpiPen and naloxone, so that if someone has an overdose, every once in a while someone smuggles in, despite our efforts, might smuggle in opioids and use them on the unit and go down. And if they do, you have to be able to immediately respond and work on that. And then having kind of screening equipment at the entry level at our crisis receiving centers with wanding, so that we can look for metal objects and guns, weapons, knives, and stuff when people are coming in. And then one of the last really important parts of equipment that is going to tie into, as I talk to you about the community design of your system, is pharmacy and meds. So thinking through about having the right kinds of medications available for staff to be able to prescribe and use for people, that helps keep them safe for both medical things, nicotine replacement if it's a non-smoking facility, so that that's not a problem in terms of agitation and frustration, and then medications to help support people that are going through withdrawal, medications to help support people that need treatment for substance use, and medications to help support them with any of their mental health concerns or issues that they may need. Another tool that we use at RI is something we call high-risk protocols. So it is this concept of anyone can, going back to that safety culture, anyone can report a concern about safety to a leader on the staff who contacts the provider. And we have a discussion about, we're worried about that person's safety, and the provider will talk about interventions and things that we can do. And they'll put orders in the system that could include changing someone's level of observation. So maybe we're worried about them trying to pick up objects and swallow them on the unit. So, and they have a pattern of that. So maybe we have an alert in the electronic health record that says Sally likes to go pick up things off the unit and swallow them. So we're going to make a choice to put them on 1-to-1 within arm's length so that we can keep a real close watch on them, and that assigns a staff member to that one person. So as you can see, it's a challenge, but it does increase the staffing for that particular shift when you have to do something like that, the staffing needs. But it can be a real important piece of keeping Sally safe while she's on the unit and working on helping de-escalate her crisis. And then we use this process. We have this protocol in place. So we'll have an alert in the EHR so that people can see it. And we're supposed to do a team check-in at least every shift change about, can we take the person off of that high-risk protocol, or have they improved? Are our interventions working or not? And so it increases team communication and awareness about it. If you guys are designing a system and can have something like that, and especially if it can tie to like your bed board or your bed scenario census, so that people can walk in and see, oh, I've got 6 people on various kinds of high risk concerns: seizure risk, falls risk, harm to self risk, harm to others risk, trying to escape risk, those kinds of notifications, so the team can have a macro view and be aware of safety issues that are going on. Another tool to think about related to risk is, all of you probably, as you're designing your system, there's going to be certain levels of observation that you have to do in crisis. And a common one is like Q15 checks. Their technology has continued to advance more and more with tools on tablets, so that you don't have to just do it on pen and paper, and staff can go around and see people and engage with people and just click off their safety check and what they're doing then. And even now they're being able to create patterns of tables that can show you how people slept during the night based on the Q15 checks, at their movement, their activity, their level of their rating of how they were with the interventions and those kinds of things. So it can give back a lot of cool data and dashboards and information about the milieu and what's going on the floor. And just a few other electronic gadgets and gizmos I'll mention related to safety. There's continuing development on units about ways to help staff feel safer. And there's different versions of like alarms or alerts of different ways where people can have like bracelets or necklaces that go around their neck that you can pull off real easily. But when they do get pulled off, it automatically signals an alarm for all the staff to be aware and to come, to be able to come and do that. So there's just different uses of electronics and technology to develop new ways to try to improve safety and make it easier for staff. So I definitely would consider exploring different options as you're designing a system. Then having assessment tools that help the staff with safety. So this is a new tool that we developed to rate all of our sites in these different areas of environment, staffing, training that we're doing, types of medication options and things that we have for treatment options. Does the site have that? Does the site have KPIs and systems in that Project Renew setting to be able to review all seclusion and restraints? Are they using high acuity protocols correctly? Are we doing video debriefing as teams when things don't go well, so that we can learn from things? And we give a score, and then we create action items based on that score for continuous quality improvement. So thinking about having systems that measure these elements of safety and how well you execute them, and having someone score it, own it, and creating action items that the team is working on and seeing, are you making improvements in that or not, is a big element of executing the performance of safety that I would encourage you guys to be thinking about as you design. And then finally, remember we talked about the staff needing to feel safe to give good care. On our incident reporting system, we have this open survey that allows any staff member to go in and kind of say what their role is and be able to answer the question, am I feeling safe at work today? And if they're not, it can prompt them in a category of about 5 or 6 major categories of things that they've got concerns about. And it gets directed to both QC as well as the site supervisor, so that there can be, if we get a spike in different staff members reporting safety survey concerns, it gets alerted, and then we can go back to that site and have a leadership huddle and work on connecting with the staff, finding out what's going on, what's happening, and how can we work as a team to improve that feeling of safety for them, because it's really important. And if you don't get that right, it affects turnover, it affects their care of other people, and it can really affect the morale of the staff. So I do encourage you to have some kind of way to make sure that staff are being able to voice their feeling of safety and give feedback and ideas about that lets them feel safe, including a way to do it anonymously, which they can do through our QC like ethics line if there's a concern that they don't want to voice it coming from them about something that's going on. So those are some of the tools and some of the 4 things that to kind of summarize that I was talking about that I feel like that we can control. However, I'm going to give this next slide to you guys as you are working on trying to develop a system and using inputs from us and other experts on thinking about it. And it really does take a village, and it takes the community thinking about all these elements. Every time we come into a new state to do crisis care, we see how lots of different elements of what the community and the stakeholders of the community have that are different in different places can impact our ability to provide safe care. So some of those things to think about, one of them would be licensing. So however you're going to license your crisis centers can have a big impact on how that correlates with billing codes, how it correlates with what you can do or not do at that site. It can affect interactions with the Board of Pharmacy based on how you're licensed that might impact whether or not you are able to have your own meds there, such as like intramuscular Ativan to help with agitation for someone who's coming off of stimulants and needs an immediate medication. If the Board of Pharmacy doesn't allow your site to have that and doesn't treat you as a level of medical care like an emergency department would kind of have, or at least up to certain standards, it really impairs your ability to help serve people. Because if you have to wait and go pick up medicines from a pharmacy, you're just never going to be able to do active, immediate, urgent needs that people in crisis have when they come to crisis centers to really be able to serve all. Coordination and how that's done in the community. So are you able to help set up systems that make it easy for ACT, assertive community treatment teams, to interact with crisis services? Are you making it easy for information to be shared and passed around about people who utilize emergency departments, crisis centers, mobile teams, call centers over and over and over again, so that you can be aware of that and work together as a team to support that person better and help with that? I mentioned the pharmacy piece. That's a really big deal. Making sure that you look at the legislation and work with your Board of Pharmacy to create and actually I would encourage you to get expertise if you're going down that route, to get expertise from other states that have been doing it for years safely, so that boards of pharmacies aren't scared about safety concerns related to med diversion or med administration safety. And so looking at ways that can be done correctly but safely as you set up that. Involuntary commitment laws can have a big impact on the way that services can be done. And it also, again, goes back to licensing. If your crisis centers can't accept people who are on petition or whatever the particular type of involuntary commitment process that your state has, if it can't coordinate well with the licensing of the building that you have, you're always going to have people that you can't say yes to, and they're going to end up in the emergency department waiting, usually is what ends up happening. Silos of avoiding silos as you're developing your system is a really, really important thing. One of the common barriers that we've seen in some states as they're developing their system is trying to separate out mental health from substance use completely, because, you know, over 70% of people that come into most of our crisis sites have both. If they have substance use, they also have other mental health diagnoses or issues. If they have mental health issues, so many of them also have comorbid substance use. And so when you try to separate those things out, it can really impact access to care, people waiting, bottlenecks in the system, versus if you just create a system that has the ability to care for both at the same time, you're going to be much more likely to connect and engage people and help them feel welcomed when they're in crisis to get the kind of support that they need. And then finally, funding. You know, there's a lot. I just described a really robust, you know, say yes to everything type of crisis center. There could be other crisis centers that don't staff 24/7 with medical nursing, that don't do the higher acuity thing that requires staffing expertise and the training and those things. However, if you don't have that, then your only option in your community for a lot of group of people is going to be emergency department or going to jail and dealing with law enforcement. And so making sure that you can have all those other layers of continuum in your community, but you have to have that emergency version, or else that's what happens. And when that happens, I will promise you, people in marginalized populations will be the ones that will disproportionately bear the brunt of lack of access to care and being more likely to get into the system of incarceration and those kinds of things. So it's an equitable and the right thing to do to think about as you design your system, to make sure that if somebody's going to commit to doing the full on, really work through that it gets funded correctly to be able to support it. So, I'll leave you with this story, and I'll go back to Disney again. One of the things I love about Disney is the storytelling and the experiences they do. There's this ride in Epcot called Spaceship Earth, and if you've ever seen Epcot before, it's the most famous symbol of Epcot. It's this big metal-looking golf ball. And when you ride the ride, it takes you on a tour through the history of mankind and how communication has affected the development of mankind. It goes from historic, writing on stone walls all the way through to the end of the story with technology. It's a little bit dated now, but at the end of the ride, they take pictures of you on the ride, and at the end of the ride, on this little touch screen in front of you, you get to design what you would pick for your crisis system, and you kind of get to pick the things that not for your crisis system, you get to design what you would pick for your life. Are you more of an outdoors person? Do you want to be able to teleport to work or drive to work or ride to work, or do you want to work from home? And you pick out these different things, and then it tells this little cute story with your photo about what your life might be like that walks you through different elements based on what you pick. So you guys are embarking on, as we go through 988 and work on developing crisis systems, we have a chance across the country to really impact and create a system of medical emergency care that's equivalent to medical emergency care we have now, that creates access for all people in an emergency basis, that has different layers of care so that it fits what people need and doesn't force them into just one option. We have the ability to help really remove law enforcement out of having to do mental health support out in the community. And we have the ability to create really good care that's supportive and helps people, instead of making them jump through hoops or feeling like they're running into walls or facing significant stigma when they try to reach out and get help. We have an ability to help families of and loved ones of people who are going through these situations too. And it all comes down to thinking about these types of things. And this is just about safety and security. But I hope through some of the things that we're going to continue to talk about, that we can keep to add on layers, and that you'll be motivated to think through, how can I create a system in our state that has these things put together from the beginning to let us have the room to grow those kinds of systems? Because it's still a win-win business case when you do that, and you keep people out of jail and you help them get back to home sooner. I mentioned in Peoria, that site has 82% law enforcement drop off, but out of that 23-hour site, I think our numbers are up now as of this past few months. Over 70% of people are returning to the community within 24 hours. And a lot of them came in with police bringing them in. So we're actually working on being able to help have a large number of those people have their crisis resolved so that they can return back home and not have to go to a long-term hospital or wait in the ED. And the fact that law enforcement was able to bring them in, and again, we want to keep working towards building a system where law enforcement isn't the primary responder for these things, but because that is the place that it is in Arizona, at least that all law enforcement knows they've got a place where they can go take someone to get care. So you have a great opportunity to do that. And I appreciate your time today and letting me be able to talk about some of these elements of safety and security. And now I'm hoping I can open up the floor to talk about some questions. And if I glossed over something or didn't cover something as much as you would like me to, that we've got time set aside to talk about those things.
Thanks so much, Dr. Chuck, for this great presentation. I have a few questions I was jotting down, just really pertaining to that last slide you shared. I think one thing that stuck out to me is you mentioned ACT and the importance of that as a discharge resource from your crisis stabilization centers. And I guess just wondering if you could speak a little bit more to like the availability of ACT in Peoria and some of the states that you work in. Thinking about here in Anchorage, we have one team, right, that, can serve 50 people for a community of 300,000, right? And so, we're constantly hearing that that's not enough. And so do you have enough when you're trying to discharge people?
That is a great question, Becky. And the answer is it depends on what part of the country we're in. I'll give you some ideals. There's certain areas where we have ACT teams that we have such good interactions with their ACT teams, and they're so engaged that they actually have staff coming to the crisis center to see their folks. If they come in, they use our crisis center instead of the emergency department and things like that to come when someone's in crisis and needs a higher level need. They need to go somewhere temporarily. We have our providers have the ACT team doctor's cell phone so they can trade information and understand, because ACT teams really get to know their folks that they're serving if they're doing a good job. And we want them to help coordinate and guide the care of what's going on. They usually have a really good sense of what's going on about the crisis, what works for that person. If the person has psychiatric advance directives done with them, they can share them with us. So in an ideal scenario, that's the most robust interaction and we also identify people that we think might be good candidates for ACT services based on people that come into our site a lot and are using emergency services a lot, are struggling with connecting in their follow-up to their outpatient care and might need a higher level of engagement or have higher risk things with their mental health and or substance use and or medical concerns that would benefit from that higher attention of a multidisciplinary team. Then we have other communities where we just cannot get the ACT teams to engage with us. And I guess the combination of the ACT teams and then the folks that are in charge of supervising those ACT teams and the services that we provide might not put as much pressure as we would like to have them perform in a particular fidelity way that they should. And so that can be kind of, then we're left dealing with trying to help support as much as we can some of the things that maybe an ACT team might not be doing. I've got some ideas and thoughts too while we're talking about ACT. So I think that coordination is really important, but you definitely also want to know, a certain percentage and use data in Alaska to figure out how many more ACT teams would you need. And I know it's super hard. I've worked on a rural ACT team for over a decade. And when you've got intense rules about fidelity and you've got people spread out in a rural area or in any situation, the more spread out they are, the harder it is to serve a larger number of people because it just takes so long to go spend on those multiple times a week visits and those kinds of things. And it's tough. And so using technology, I think telehealth is a good frontier to help improve that and to improve connection and being able to support and connect with people more often. But it's a tough line. I think one of the things that we're working on at BHL is also thinking about what are some other ahead of the way things that maybe, if mobile teams have the ability to follow up a few times and do some of the functions that an ACT team does longer term with someone, there might be a population of people who might only need mobile support, but if they could get follow-up that has that engagement aspect for, a few weeks that has access to a provider who can help prescribe things, get somebody back on their medications, get somebody connected to a few things that might make an element that maybe that it could get another pool of people that sometimes slip through the cracks and don't really get help until they get to an ACT team. There might be some other elements and ways to morph things that you're doing that can offer some things that's separate from the main function of mobile support. It's another add-on, but I'm just saying in terms of innovations and things that I'm seeing being conceptualized to overcome some of those barriers, Becky, that's some of the things that come to mind. Did that answer what? Okay.
Yes, thank you. That was great.
Was there a chat question, I think? Oh, no, thank you, Eric.
And I have some other questions, but I don't want to hog the question line. So give others an opportunity to jump in. Otherwise, I'll keep rolling. All right. So again, in the end of your presentation, you mentioned involuntary commitment laws. And I guess I'm curious, so here in Alaska, and I'm just not sure what this looks like around the country, we have different statutes that govern involuntary commitment or emergency detention for people experiencing a psychiatric crisis versus people who are intoxicated or incapacitated by drugs or alcohol. And so just thinking about your facility's abilities to accept people, if those things are separate in Arizona or elsewhere, how does that impact your ability to accept people?
Yeah, in general, again, going back to that right door or no wrong door concept, is we just try to take the state's rules and figure out ways to be innovative to support that. So like in North Carolina, where I live, there is a substance use commitment. It doesn't get used very often. It's mainly what will happen is someone has substance use things going on that make them acutely imminent dangerous in the views of the people that make those decisions in the moment. And then what we do is we still are able to execute per the law in different states based on how that goes. But our goal is to be able to help, if it's related to substance use, to help be able to convert that person to voluntary as quickly as possible, especially if it's related to just a momentary thing related to their intoxication. While we're talking about involuntary commitment, though, I would like to just talk about like the differences in different sites that we work on and how it impacts our need to be flexible. So you can think about it. You can do anything to figure it out in Alaska. I mean, I'm sure Jamie's probably already knows what your rules are and can help guide that, but there's always a way to figure out how to do it. There's some states where, the person can be petitioned for an involuntary commitment by anybody, any citizen. And then if it goes to a magistrate at a court who decides if that's going to work or not, and then they get picked up and brought to a facility. And then there's a primary evaluation by a psychiatrist, and then it has to happen within 24 hours. And then within the next 24 hours, they have to have a second opinion if they're going to keep them on. And then they have about, anywhere from 7 to 10 days in a lot of states before they would go to court to then make a decision if they still felt like they needed to be on a voluntary commitment. So that's one element. So we would have to have enough MD time to be able to support doing the evaluations. Other states allow nurse practitioners and licensed clinicians to do the first evaluation. There's some states that won't allow psychiatrists to do the evaluation and have state hired mental health professionals who come to our sites to do their part of that petition process. There's some states where we're not allowed to put people on, but we accept people, but our psychiatrists can take people off. So, I mean, there's so many variations of how it can work. And so you have to create your workflows. But one thing I'll consistently say, and it's one of the tough things in Arizona, is that almost all of our other sites, we get to work with people in our short-term stay units that are on involuntary commitment for a longer period of time. Whereas in Arizona, people, they have a very short window. You have to make a decision within the first 24 hours, whether you're going to send somebody to a designated facility that handles people on involuntary commitment. And so at a lot of our other sites, we can make the decision that right now someone is imminently dangerous, but then we can collaborate, work with them, and maybe in 3 days, things are so much better if things go well. And I'd say, in North Carolina, our voluntary conversion rate is like over 90% in that short-term stay unit. Very few people that need like a longer term inpatient stay. So I don't know what your rules are, what your laws are, but that's one thing to consider. If there's an ability to flex it, it's given a crisis unit, especially if you're going to do some short-term stay units, the ability to work with people collaboratively so that they can have that connection, say, we're going to work together so you can go home in 3 or 4 days once you're safe and once you're feeling safer and things are better. That can be a big win to help improve collaboration and connectivity together on a recovery path if you can do that in your involuntary commitment scenarios.
Hi, my name is Rebecca Pillais. I'm a community engagement partnership coordinator here at the VA. And I was actually wondering about the Compact Act and if you've noticed an increase or anything with that, especially with the follow-up, the suicidal ideation and follow-up care working with the VA and this crisis response.
Talk to me about some of the elements that you want me to discuss, Rebecca, related to
the Compact Act that just recently come out. I mean, I didn't know if it recently came out. And so for hospitalization of veterans with suicidal ideation, and then they also are able to go ahead and get inpatient care paid for and in residential care paid for.
I think the reason I probably don't have Jamie, I don't know if you've got some feedback on this, but what I would say is, again, because we're kind of a a no wrong door. We get veterans, especially if we have a higher concentration of veteran population in particular towns or cities that we're in. We get them coming in, always have, and then try to help coordinate care. We're going to say yes. We're not going to say you got to go to the VA. We're going to help work with you, keep you safe, work with you, see if we can return you to the community. But if not, then part of our follow-up and connectivity would be to move that. But to be honest with you, Rebecca, I'm not sure if since the act, if it's trended any kind of major increase in that for us, because we've always kind of, especially at some of our sites that are near military bases and things like that, just it's not uncommon for veterans and or active military to use us as much as they use the VA when they're in crisis. I wish I had. You got any other thoughts on that, Jamie?
Well, and it hasn't changed for us because that's really kind of a funding mechanism. And as a no wrong door for us, we would say yes, regardless if somebody had insurance or didn't have insurance. So if somebody presents need this level of care, we're going to go ahead and say yes. So we haven't really seen marked increases in the amount of veterans or folks on that status that are coming in. It's about the same that it's always been. It may help us a little bit in some of the discharge planning and coordination of care, you know, because folks are a little bit more comfortable getting care if they know it's not going to cost them. And while it doesn't cost us when somebody's coming into our system, obviously aftercare may have some cost with that, especially if they're, you know, 6 months out of service. So we haven't seen an increase in the number of folks coming in, but I think that's part of the way that we set the model up is you don't need any insurance, and we're going to go ahead and be an essential service and be able to cover your first 24 hours.
Okay, no, that makes sense. And so, yeah, the aftercare part with the pharmacy and the medications and things like that, it would cover, but get veterans fear of like, how am I going to pay for the transportation and how am I, you know, whenever I get to the hospital and things like that. Yeah, I understand.
Yeah.
Thank you.
Rebecca, you brought up a really one other element that's a really important thing that I didn't cover in this talk, but I'm glad that you sparked my thoughts about it. And that is, as you design your system, all of these elements are immediate in the crisis moment. A big part of treatment, whether you're dealing with someone who can resolve their crisis at the call center level, at a mobile dispatch level, or at a crisis receiving center level, if you don't have connections in your if they don't have a connection to the resources and an investment in systems that work on connecting people in a good way to follow up and ensuring that you're monitoring how those outcomes and that movement is occurring, you are doing what you need to do in terms of creating that emergency system, but we're still missing the mark for the overall system because you really want to make sure that you've got connections to help support those next steps. So safety planning, crisis planning, connections to next steps. How quickly can you get people into those? Can you help create stakeholder connections so that you can help get people connected to referrals quicker from a mobile team when they're out at 2 a.m? Is there some kind of system to be able to see where those things are? Some really neat things that some communities do is have systems set up where the outpatient referral sources for a crisis receiving center come in and do a telehealth thing with the person they're going to see next week and say, hey, I'm Deidre. I'm going to be the clinician that's going to work with you when you come in. I just wanted you to see my face. I'm going to look forward to seeing you on Wednesday. Things like that are mucho helpful in safety and keeping people connected and engaged to that next step in their recovery when their crisis has improved enough for them to move forward.
And to kind of piggyback that a little bit, it is about the system approach. So my name is Jamie Sell. I'm the Chief Strategy Officer with RI International. Supported some of the reporting and some of the technical assistance that we've done in Alaska. Becky was talking about ACT teams, for example. So what we tend to see in a community is the stronger the integration between your systems, the more of a safety net you're going to have for your people that are in crisis. What I do see as I'm doing consulting both nationally and internationally a lot is people say, well, we created this crisis center, we're done. We've got everything we need because we've got a crisis center, we've got that safety net. Well, what we do tend to see is that's a good first step. Got to have my call center working well. I've got to have my mobile teams. I've got to have my facilities. But if you look at the evolution over the last 30 years in Maricopa County, what we did is we started leaning into crisis services, realizing that we decreased ED costs, we decreased Department of Corrections and jail costs, decreased a host of other unnecessary inpatient and costs. And what they started to do is then put that back into the rest of the system. Not 100%, but a good percentage of it came back into the system. So if we talk about ACT teams, which we think are absolutely integral, SAMHSA evidence-based practice, Maricopa County has 23 mobile teams, 100 slots each for 4.497 million people. So it comes out to about 1 slot for every 2,000 people. Now, the reality is we didn't always have those numbers. But as we start seeing savings in people being in the state hospital too long because they don't need to get there, people being in private or public inpatient psychiatric hospital with an 11-day length of stay, people who can get caught early and be discharged, like 70% of our folks in the first 24 hours, the system sees considerable savings, which it can then reinvest into 2 types of programs, we believe. One is prevention, right? If we can support somebody in same-day access to see a psychiatrist who missed their last psychiatric appointment, I can get them an intake tomorrow with a clinician and not need to wait 2 weeks. We can kind of start to head some of these things off. If we can increase our percentage or our numbers of permanent and temporary supportive housing solutions, which ultimately is suicide care, right? And then we can start to look at the back end and say, look, if we can go ahead and get somebody out of our facility a little bit quicker because I can get them a next day appointment, I can help them with some stable housing, I can get them into a respite or residential level of care, I can get them into day treatment, partial hospitalization, I can continue their MAT or their medication assisted withdrawal and so forth down the system, then really my system is working really, really well. So when we start talking about the results that we get, I think what we talk about is this is part of a complete breakfast. If you drop the best functioning crisis center into a community with all the right policies and procedures and training and facility set up the way it is and good regulations, but I don't have the rest of my community prepped to keep people out or to accept people back, it ends up becoming more like a longer term state hospital where the only room is for the most acute folks in my community. And we're no longer looking at crisis stabilization, we're looking at longer term care, if that makes sense.
Yeah. Thanks, Jamie. And one other thing I just thought about related to safety and follow-up is all that I didn't mention in the talk is thinking about things that you can do to connect people to improve their safety. Besides just their getting to their follow-up is some other kind of harm reduction things. So almost all of our sites have connections with the health department or some kind of programs to pass out naloxone or Narcan for folks that have either risk for opiate use, or if we've got some of our communities have really bad penetration of opiates and fentanyl products mixed into cocaine and amphetamine. And so offering that and having that accessible as a harm reduction measure, really not just focusing on one of our other peer power practices is whole person wellness. So it's not just their mental health or substance use, but also thinking about medical things. So working on identifying major safety risks on people's sugar and blood pressure and stuff. And even if it doesn't keep them from being at our crisis facility because it's not so acute that we can't work with them, helping to encourage and connect with them and engage with them on going to get their medical care and things connected and started and done. Helps the overall community public health and those kinds of things. So as you're developing your system, encouraging the providers that are going to be doing these kinds of care to think about it in those terms too, because they have a better ability to connect and engage with people who maybe a lot of times don't get medical care on some of your big top 5 or 6 major costly medical things that typically hit some of those populations. And you can make an impact on identifying them, connecting them to care and doing those kinds of things. So again, it's not just about money. It's good for their health and it's good, better public health, but it does make it is a way to make an impact with what you're doing by building that into your system design and being thoughtful about that. And Rebecca, I'm sad you cut off your background. I was really digging the background with the green lights. My neighbors just got back from a trip on their bucket list to go see them, and we're in that like little igloo things and would get out and it would be like, I don't even know how cold. It was just like a few days ago, a few weeks ago they got back and it was so cold in the middle of the night. So I'm glad we're doing this via Zoom. They said it was beautiful, Thea.
Dr. Chuck, I have a question about in your facilities. You mentioned, RI facilities would do debriefs after some events. Like, what's the cutoff for when debriefs or root cause analysis happen? Is it after every emergency medication, or does it depend on like every physical restraint instance, or does it depend on the
premise and
facility?
ideal is to our premise and ideal is to do a video debrief of all seclusion and restraint events. But then we also have multiple mechanisms of that. So it's done in the unit by leaders within the unit. And then for things that get raised to us, and we have an electronic incident reporting system. So we have dashboards on how many it's happening, and we do quarterly reports looking at the overall system, both chemical restraint events as well as seclusion and restraint things, even if we just put hands on for just a few seconds and it doesn't result in anything else like that. And then we also, if it's a major like Sentinel event, that can have like a root cause analysis where QC is involved and we do a whole process of evaluating things that happen, what worked, what didn't work. We have a peer review safety process that can happen. That's a confidential within the company quality improvement. We evaluate it with purely from a quality perspective to understand what we did well, what we didn't well. We use people from another area of the country to evaluate an incident that happened in that area of the country. So there's a lot of layers of things that you can do in your tracking systems and stuff. One other cool thing when we talk about safety and talk about interventions in that way, Megan, the Crisis Jam this Wednesday coming up is going to feature a really cool technique that we use called UKARU, and going to talk about those. And this concept, 2/3 of UKARU is about trauma-informed care training and staff. It's such an amazing job of teaching staff how to think about the neurobiology of trauma and how it affects our actions when we're scared. I could just see my sons, they have pictures of the image of the brain and different traumas to show, and I could see my son back when he was young running into the woods, probably what was lighting up in his brain when he saw that guy come out of the woods with that mask on. But it really does a great job of teaching you those kinds of things. But then separate from that, it has a system that they designed using pads that are always done in a retreat intervention only, never offensive, not like riot gear at all. And we leave them out on the unit and guests can pick them up and hit them and touch them and do whatever they want to do with it. And we found that it markedly reduced our seclusion and restraint events because you don't have to put hands on people so many of the times. It's also super helpful to make these small pads that if somebody's like banging their head, you don't have to like put them in restraints. You can actually slide the pad under their head and comfort and talk to them while that's going on. So it's got some cool features, and they're going to be featuring that on the learning community on that Wednesday. So either catch it or catch it on YouTube. It'll probably be really cool. But going back to system design, one state in our that we serve in does not allow UKARU. Not because UKARU did anything bad, they just have a state approved de-escalation technique that they allow, and it would actually take a pilot program to let us start using it, even though there's really good evidence, and it's amazing in the way that it works, and it's been used for a long time in lots of other states, and it's only just one that we're dealing with this regulation. So again, it's a system thing where we're having to be malleable and figure out what we need to do, and we're working with their stakeholders who actually love it and want to work on helping figure out ways to let us be able to do it. So it's just stuff like that comes along that you can have all the best controls in the world, but you still have to work within the system of the community and figure out how to overcome certain, different barriers. So you guys are designing that right now. It's cool.
I really liked when you spoke about the staff safety survey. Could you just touch on that a little bit more in terms of
Sure.
like, is that something you implement universally in your facilities? How often? What do you do when you're getting data as an individual follow-up? Do you track it to see patterns in,
I do have some thoughts on that, Becky, and I'll give you our history. We cared about doing that. Historically, the only way we knew about it was through complaints that escalated up, and a site leader would know that something, that staff was upset about a particular thing and work on it internally. We wanted to have more database dashboards to take a look at how that was going. So years ago, we tried this like safety survey that had more questions, and we would like universally put it out to all of our staff all over the whole company and say, please fill this out. It was hard to get engagement on it. It didn't really have definitive information in the moment about what was going on. It was just a one pulse in time. And crisis care is so different. You might feel great about how things are going one week and have a really tough moment that's tough, that kind of thing. And so it lacked that, and we didn't feel like it was impacting. It felt like we were doing the survey and saying that we were caring about checking on it, but we didn't feel like staff necessarily had the feeling that it mattered. So then we created this tool, and it's built into our electronic incident reporting system, which any staff member can access. And it's just an open thing to click on it. And it's just one question. And it has ownership, and it is going to get answered by someone. It loops to QC and to site supervisors so that they can see the outcome. Now, what I'll tell you is it goes dormant. If people are not feeling unsafe, they don't answer it. They just don't get on that machine and do it. It only happens when something happens, and then you can get a flurry of them. And so what'll happen is we'll get our QC leader will say, hey, we just had a flare up in so-and-so of some safety concerns. We need to set up a little quick group meeting, and we'll do like a 10 or 15 meeting with the leadership and say, here's the concerns, what's going on, what supports do you need, those kinds of things. So that's the evolution of that tool and how we did it. Now, in an ideal scenario, and we haven't been able to figure out how to do it yet, I would love it that when staff would be able to have that same question, but it somehow be that like when you log on your computer to do work, that it just pops up and you have to answer it right then in the moment so that you get more engagement in answering it, not just when you're upset about it and you would answer, and then you could really look. We haven't been able to really figure out how to operationalize that in our different, we've had ideas, but haven't gotten to operationalize that. But there is always that open access. And
Yeah, that's really interesting. I guess
Yeah,
that's what
Becky,
I was thinking. I was like, is it like, something that people are answering every time they clock in or whatever? But, obviously a lot of, potential technological barriers there. And, maybe they're feeling safe when they walk in, but not when they're leaving or, a lot to think
Right.
about. So
It's important to note that we're also going to look at other factors around safety. So when you've got a safety survey, understand it is a perception of care survey. It's do the staff feel safe? What I can tell you is I've worked a lot of units over the course of my career that probably were unsafe, but based on my size, I probably did feel safe. We will get sometimes feedback through that someone's unsafe, and we'll go and actually look in and look at the root causes. And it's not a lack of training. It's a particular staff that may feel unsafe. So really what we do is we say, okay, this perception is going to lead us toward things, but we still have to look at what are the numbers of our seclusion restraints? Are our policies up and running? Is everybody trained? Did we do our practice trainings within the last month? Are we starting to slide on that? Have we stopped taking an interest in the environment of care that we're actually utilizing? And do we have throwable chairs on the unit that somehow snuck on? So you still have to say, this is one aspect of understanding globally whether or not your unit is safe. And having a staff say, I don't feel safe, doesn't mean it's not a safe environment. And not having staff not say that they feel safe or don't feel safe doesn't mean that you actually do have a safe environment. You've got to use it kind of globally with some other indicators as well. And I have seen folks that just say, nobody complained, so I assume we're safe. And probably not. You're just waiting. You're waiting for a problem.
And that goes back to that original concept that there's versions of safety. So when you think about safety, understand that everybody has their different view of it. I've definitely worked with some nurses who, no matter what the data shows about safety outcomes, that they will say, if it's not staffed 1 to X with nursing, it's not safe, because that's what I learned in nursing school. And it's just it's a perception. It may not be reality with that, just as an example. And then, like I told you, like when staff really are confident in their techniques, they may be in a super high acuity setting and feel safer than a group who doesn't normally deal with folks with high acuity, who just doesn't feel safe because they don't feel confident in their skills if something does go down. And the data may show that nothing's gone down in the past year, but they still don't feel safe. And some of that may be in their training and their confidence because they don't use their skills that often. So it's really interesting, the dynamics of that.
Right. Well, given we have 1 minute left, should probably stop asking questions now, but really appreciate your time and all the information you shared today.
Thanks, Becky.
So,
I think
thank
we're
you so much.
I hope to see all of you back and bring more people too. I think there's one coming up in a few more weeks. We're going to talk about the fusion model, which is going to really get into the blending of peer support with this medical stuff. So I hope I'll get to see y'all.
Yes, so everyone, that webinar is scheduled for Friday, April 21st from noon to 1:30. So if you haven't received the registration link for that, please reach out to Megan or myself and we can make sure that we get that over to you, and we'll be following up with that information and the recording for this webinar. So
Thank y'all.
thanks, everyone.
Everybody.
Bye.